Cardiogenic shock is a real challenge, and it's one that is getting more and more common, sorry to say. In the February 22nd issue of JACC Interventions, there is a paper that is talking about the temporal trends and outcomes of patients undergoing PCI for cardiogenic shock, and it is a report from the CathPCI registry. And there's an editorial comment by my guest today, Dr. Tanveer Rab, who is an MD and an associate professor of medicine at Emory University School of Medicine in Atlanta. Your paper is disappointing results, but we must carry on. These really were disappointing results. Can you talk a little bit about the paper, the main paper in JACC Interventions?
So the paper is an excellent review of the outcomes through the CathPCI registry. And the shock trends are, cardiogenic shock trends increasing. And we had hoped with modern technology and whatever is accessible to us in the United States, being the most advanced technological country in the world, we would be able to make a great impact in saving lives, but unfortunately that is not the case, and that is disappointing. So the disappointment really stems from the fact is what are we doing different and what should we be doing differently?
I mean, it's not just a challenge. The data seem to suggest that the mortality was getting worse.
That's correct, it was. It had gotten worse despite these modern advances. That's correct.
So what are we doing wrong, or what do we need to be doing?
So the initial thought was, since there were so many PCI centers that opened up in the country, people were not getting advanced care that tertiary care hospitals provide. But that is not the case. They were doing equally well or better. But what had happened was that people were not providing total revascularization to these patients. They take just the infarct radial artery that the felt would contribute to the shock in patients with multivessel disease, but not revascularize everything. And according to the ACC guidelines, if somebody in shock, you are allowed, and it's a class 1 indication to revascularize everything. That's number one. Number two, what I felt at that time was that there was a temporal trend in using or increase in the use of bivalirudin compared to the older anticoagulant heparin plus the glycoprotein 2B3 inhibitor. We know that the platelets are very hyperactive between patients with acute myocardial infarction and shock. And in the earliest studies from Horizon Acuity, they had showed that a small percentage of patients would have stent thromboses because the platelets would not be completely inhibited on bivalirudin alone. And these patients would require pre-treatment with clopidogrel. Now, in a patient with shock who is hypotensive, I mean, giving oral clopidogrel has issues with absorption of the drug. And if you're not preloaded adequately, which is shown in the Horizons trial, your bivalirudin may not be effective. So the issue of absorption of the antiplatelet drug, the thienopyridine clopidogrel, is a big issue here. And if you're giving bivalirudin is not going to be activated or active in suppressing or causing adequate anticoagulation in these patients. So that's the second issue. And third, the use of high-tech LV support devices, even though they were available in the last decade, and even in tertiary care centers, was not being utilized promptly. Now, there's not a lot of data on, except for Protect PCI, which was in a sort of a semi-elective situation of using high-tech LV support devices pre-procedure. We know that the use of the Impella is very useful in patients with high-risk PCI, but the literature to suggest that it ought to be started up front cardiogenic shock meager, as well as the other LV support devices. But we do know that placing these LV support devices pre-procedure has a huge advantage in saving lives. I mean, the number of smaller shock studies that show that if you put the devices in earlier to provide LV support, whether it's the Impella or ECMO or tandem heart, it does provide you a source of benefit. And even though the mortality rate might be high, it's still lower than doing it without these devices. So, for example, in some very sick people, the cardiogenic shock rate and mortality would be closer to 80%. But if you put these devices in, you could possibly decrease it down to 50% or so just by putting the devices in prophylactic pre-procedure. So that was not being utilized, even though the Impella was available, and most experienced cardiologists can put it in very quickly in the cath lab. That was not available. So that was the other thing that was not utilized pre-procedure, even in tertiary care centers. So a combination of what I think is inadequate pre-clopidogrel absorption, use of bivalirudin rather than heparin and glycoprotein 2B3 inhibitor. And we know glycoprotein 2B3 inhibitors are very potent antiplatelet inhibitors, and they were not utilized as frequently
Generally,
in the last decade, and there's been a decline in the use
But
in the last
in
decade.
this setting, you're saying it's important.
If you use heparin, you should use a glycoprotein 2b3 inhibitor, particularly in this setting. So,
What I thought was bizarre was they're using fewer drug-eluting stents in this particular population.
yes, there was a trend in the last decade where people felt that drug-eluting stents are more thrombogenic than bare metal stents, but from the SCAR registry from Sweden, which is not a shock study, but they showed that the long-term outcomes of the second-generation drug-eluting stents was better than bare metal stents. So now that issue is sort of sorted out. I think most physicians are putting in drug-eluting stents in patients with an acute MI and shock.
I did find that on a positive, if not confusing note, low-volume PCI centers seem to do well.
Yeah, but one of the things, the caveat to that is that low-volume PCI centers are very close to where the patient lives. So if the patient is sick, he's going to get there sooner. Number one, and they will do and they get earlier care, in my opinion. And sometimes tertiary care centers are far away from the very sickest patients.
So what lesson can we take away from this? I think an important paper in JACC Interventions.
Yeah, it is an important paper. I think we must carry on. But we should change our practice trends to decrease by using the criteria that the ACC has already provided, that patients with cardiogenic shock should undergo total revascularization. We need to be sure that thionyl is absorbed adequately, okay? And if they're not, I mean, we should try to use heparin with a glycoprotein 2b3 inhibitor. The third thing is that LV support devices must be used early on, okay? And that is the message I had. Now, in terms of bleeding risk that you can decrease, I think radial access is very important for these patients versus femoral access.
In this setting, it seems like following the guidelines really could be important.
Yes, yes, absolutely.
Now, the editorial that we're talking about by Dr. Rab is in JACC Interventions, the February 22nd issue, and it's disappointing results, but we must carry on. The CRT meeting, which is where we are at, also in that issue of JACC Interventions has all the abstracts. So please check out the February 22nd issue of JACC Interventions. For Cardio Source World News, I'm Executive Editor Rick McGuire.